Welcome to the Hospital Finance Podcast, your go-to source for information and insights that can help you stay ahead of the challenges impacting healthcare finance. And now, the host of the Hospital Finance Podcast, Michael Passanante.
Hi, this is Mike Passanante, and welcome back to the award-winning Hospital Finance Podcast. Today we're going to be talking about the Transfer DRG rule from a PFS perspective, and to give us her insights on what that is and what it means for you is Olga Barone-Allan, who is on our revenue cycle team here at BESLER. Olga, welcome to the show.
Thank you, Mike, and thank you for welcoming me back, inviting me back. I really appreciate it. The topic today, as you indicated, was transfer rule from a perspective of PFS. And I want to clarify, there's so many acronyms being thrown around in the industry. So PFS is Patient Financial Services. And usually that is the business office, the old, also known as the business office and billing department. Most are familiar with the Medicare Transfer DRG rule and its impact to the hospital's reimbursement. On average, what we see is that there is a 10% of all the Medicare discharges that are reduced by the reimbursement. From a PFS or Patient Financial Service perspective, it's very interesting because although we, the people within that department are responsible to collect the reimbursement, full reimbursement, but they're not responsible for coding. By the time it gets to the business office, the 837 is already coded and reviewed by utilization management and the coding department. So the business office really does not have a safety net from a perspective of the initial bill. So the only way the billers are available to or are able to identify those claims are through a rejection through Medicare, and that's through a rejection of C-7272, which means that there's an overlap or a transfer issue. Now, even though the rejections are received, there is a lot of manual work that is involved. There are a lot of calls that need to be made to the post-acute care facilities, and with the business offices and how they're structured today, there's a lot of strain and there's a lot of volume involved, not only with inpatient, outpatient. So there's not enough availability to make the constant calls to confirm the transfers and the post-acute confirmation of where the patient was discharged to. What we see on average is that 85% of the cases of the Medicare transfer rule, our providers that we deal with get it right off the bat. They code it, they bill it, they get their reimbursement exactly what is it expected. But there's like 15% that's left on the table. And for a PFS department to have to, for lack of a better term, look through, find a needle in a haystack, it's daunting. But it results in a lot of additional reimbursement that the provider, the hospital can receive. So, for those that are not familiar with the transfer rule, Medicare created this rule because they had a feeling that there was some duplication of payments. So they created the rule back in 1998 to avoid paying two facilities, give reimbursement to two facilities. The first rule impacted 10 DRGs, and now today we are up to 278 DRGs that are impacted. In our blog on this topic, we outline year by year or fiscal year of the increase, the overwhelming increase of these DRGs, and we also put a link where these DRGs can be found in table A, 7A and 7B. So if you want to do some additional research, our blog provides all that information. But going back to the transfer, in a nutshell, if in a case where a transfer, in a case of a true transfer, the full payment is made to the final discharging hospital. However, in a case of a transfer where each transferring hospital is generally paid a graduated per diem rate based on the length of stay, the geometric means. So, it's divided by the number of days, and then, the two facilities receive the appropriate amount. So to do that is very particular in the sense that at the time of discharge, utilization may not know, even though the doctor says the patient has to go to a particular facility, UR does not know exactly where that patient is ending up. The patient may decide to go home or decide to not follow the direction of the doctor. So the necessary calls, the additional calls need to be made. And that is a heavy burden for a hospital to put on to their current staffing. What we suggest is to partner with a company or vendor that really can help you, that partners with you and takes on this, has the expertise, has the tools, and can do this work that can help you collect that 15% of reimbursement that's being left on the table. Also in our blog, we have listed, the discharge status codes and the meaning as a helpful tool that might help utilization. But again, it's the calls after the patient is discharged is the key. And, at the end of every discharge and every billing cycle, that code has to be appropriate to the reflection of where the patient ended up. Now, if there are multiple codes, the HIM department has to code to the highest level of care known at that time. So it's really no fault of the coder, because whatever is in the chart at that moment is what they're coding based on. But that doesn't necessarily mean the patient is following those what's in the chart at the time of discharge. So it's really clear that to get that additional 15% that's being left on the table, the best approach that we feel is to hire a partner that understands, that has dealt with this for many years, has multiple hospitals that we are engaged with, and does this on a daily basis. This is the expertise where we really we could do 4 to 5 calls on one account just to make sure where the claim, the patient ends up, and then recommend the appropriate coding. And if there is a condition code that's associated with that change in discharge status, we also recommend that information. The one last thing that I do want to stress is that, Medicare, although it has edits in place, 90% are accurate, but there is that 10% that, Medicare is not exact. Their systems do not capture. And because Medicare has placed the burden on the provider, it's very important that these situations are reviewed, but not only underpayments, but also overpayments, because Medicare does focus on that. And so partnering with someone, an expert or a vendor that can help a provider is probably the best approach that I would recommend.
Olga, if a hospital wanted to try to improve that process and perhaps look at ways to foster communication or collaboration between PFS and the utilization management and HIM areas in order to try to capture some of those the 15% claims that you mentioned and ensure that they're correct when they first leave the door. What are some of the tips you could give them?
Well, that's a great question, Mike. Collaboration between the departments. A lot of facilities, large organizations are transferring or shifting where utilization management is reporting under the revenue cycle umbrella, which in most cases means that PFS and utilization management review, however you refer to it now at the provider site, they work as a team. So what we have found with our recommendations, and also in those organizations where they work as they collaborate, PFS provides feedback to utilization review in terms of which accounts are being coded or rejected by Medicare with this C7272. So with that information, utilization can go back and look at charts and possibly make calls to the post-acute. But again, that puts an additional burden. But there are cases in particular where there might be a misinterpretation. There might be a language put in the chart where utilization can go back to the physician and ask, what did you mean by this? Which could help in some of the opportunities that are being found.
Well, great information, Olga. As you mentioned, there's a blog post which has even more information if you'd like to go and read that. Just go up to BESLER.com, click on the Insights button, look for the revenue cycle tab, and you'll find this and a whole lot more. Olga, thanks so much for joining us today on the podcast.
Mike, thank you again for inviting me.
This concludes today's episode of the Hospital Finance Podcast. For show notes and additional resources to help you protect and enhance revenue at your hospital, visit BESLER.com/podcasts. The Hospital Finance Podcast is a production of BESLER. Smart about revenue, tenacious about results.